So CSPC is maybe a slightly different biological entity than CRPC. And the way I think about it is I think about CRPC as really an evolved cancer. And a term that I've used my whole career is treatment-mediated selection pressure. And that's basically just a fancy term to say that the more we apply treatment to this disease that we're not curing, the more the disease is able to evolve biologically. So it just goes to show why CRPC is going to be a potentially more aggressive entity. So what's really going on there? Well, I think there are a number of factors that come into play. First of all, this patient had he had metastatic disease at the time of diagnosis. This is not a person who had a screening PSA and had his prostate removed, whose PSA rose a year later. This is somebody who began to have pain in his back and was found to have metastatic prostate cancer. So right there, you know that this disease is probably more aggressive. And in fact, we've shown that people who present with metastatic CSPC, they tend to, for example, have more of the basal subtype of prostate cancer than the luminal subtype, which is more of your typical adenocarcinoma that we see in the localized setting. We also see that when people develop from CRPC, from CSPC to CRPC, and in particular when people develop abiraterone-resistant disease, we see a lot of really interesting and challenging genomic alterations. Loss of the gene TP53, which is probably the most important tumor suppressor gene in all of oncology. Loss of retinoblastoma 1 or RB1 is very common in that transition. And RB1 is a suppressor of the cell cycle. And so if that is lost, you get the entity of uncontrolled cell cycling, which leads to tumor growth. And it might be one of the reasons why chemotherapy is effective in that setting, because that's essentially what we're targeting with chemotherapy. And then there are other aberrations as well, such as loss of PTEN, which has been known about for a long time. It's not very common in localized disease, but it's quite common, about 2/3 of cases in metastatic CRPC. So a lot of us spend a lot of time thinking about the biology of this disease and trying to figure out whether we can develop or invent a more targeted approach that hits these mechanisms. And I think that that science continues and continues to work. And the need for that science is continuing as we see patients surviving longer, because patients are getting more treatment up front. And then those who develop recurrent disease are going to have more resistant disease. It's almost an irony. They're going to live longer, but their disease maybe is simply more resistant when it does develop or progress. The PARP inhibitors and DNA repair alterations are, of course, a very important observation that I touched on previously. And also, I should say that the other reason we should be sequencing tumors is for those rare instances where a patient has microsatellite unstable prostate cancer or MSI high disease. In a setting like this, I would want to know when he's developing CRPC, I would want to know if he's developing MSI high disease, because if he is, there's a high likelihood of benefit from immunotherapy. And we're seeing even complete responses to patients receiving immunotherapy who have MSI high disease. So this is complicated. It's actually really, really fascinating science and biology. And it's a real clinical and translational science for us to figure out how we can integrate new therapies into this complicated genomic environment of the transition between CSPC towards CRPC. So in summary, CRPC has gotten to be quite complicated. We now have a number of therapies available with a number of different mechanisms of action, ranging from taxane chemotherapy to AR-targeted drugs to radioisotopes, immunotherapy, and now the PARP inhibitors. How to use these therapies and how to sequence them is not fully worked out, but I think that there are some highlights that I've pointed out here that demonstrate when one might wish to use a therapy at one point in the disease course versus another point in the disease course. As an investigator into new therapies in prostate cancer, I'm actually excited about these findings and look forward to working over the next years and trying to figure out the best algorithm for patients while integrating new therapies and possibly even combinations of the drugs that we've discussed today.